Hi, my name is Christopher Voscopoulos of Medical Specialist Associates, and this topic is on using the optic nerve sheath diameter for assessment of increased intracranial pressure. This is really a super fun topic as point-of-care ultrasound begins to become more widespread. Thanks for watching, and thanks for learning with us.
Medical Specialists Associates, making medical education more accessible.
So thanks for spending some time with me here to learn about the optic nerve sheath diameter and its use in the evaluation for elevated intracranial pressure. This is really a very fun topic for those of us that are really enthusiasts with point-of-care ultrasound, but also a very practical talk. So many of us might practice neurocritical care at large tertiary care centers in which we have ready access to extraventricular devices, intraparenchymal monitors for ICP, CT scans, MRIs, but oftentimes they might not be as readily available to us as we need them, say in immediate situations. Ultrasound is usually available, so this could be something that we could do right there and then. Say if someone was in the MRI scanner for a stroke or otherwise, and that machine is not going to be available for 20 or 30 minutes. Or as we've seen, say, in the COVID pandemic, there could be times when multiple patients need limited resources at one particular time, so this could be used. This can also be used as a rather convenient thing that we can use for tracking. This just doesn't have to be a one-time measurement. We can use this to track several times during the day. I mean, imagine that if you didn't have access to, say, an extraventricular device for ICP managing, it would be very impractical to get serial CT scans of the head, but this is something that you can do serially. But maybe also from a different perspective, say if you are a clinician that has responsibilities in helping to manage off-site services, say via telemedicine, at say maybe some critical access facilities. This is a way for us to teach our emergency room physicians a technique that they could give us very valuable information for us to assess whether or not we need to institute immediate treatment in this patient population. So with that being said, let's dive into it a little more deeply. So, why are we interested in ICP management? Well, of course, we need to know what the ICP is, especially in some of these traumatic and non-traumatic brain injured patients, whether or not we need to institute treatment or not. Now, there are many non-invasive modalities to diagnose this, but many are not accurate or require significant exam skills. And during the course of this talk, we'll talk about head-to-head comparison with optic nerve sheath diameter with things such as physical exam, MRI, CT scan, as well as transcranial Doppler. But perhaps the biggest real win for optic nerve sheath diameter is that it is relatively simple to use with good sensitivity and specificity, and we will review that as we progress. So here, first, what is optic nerve sheath diameter? And so what we're really looking at here in the yellow is the optic nerve. And what surrounds the optic nerve is the pia mater. And in between that pia mater space there, when we see that clear fluid, that's the subarachnoid space. So there is a direct communication with the brain via the cerebrospinal fluid into that subarachnoid space there. And so that means that if you have an elevation in ICP, you will have expansion of this space. Let's take a peek at this on the next slide here. And you can see here that back, if you had an ICP elevation here to the right, that increased intracranial pressure would be transmitted via axonomic flow here into the optic nerve area, namely specifically that subarachnoid space, and you'd have a swelling here of this particular space here. And this is an area that we would want to measure. Now, something that will come up if you start to use this technique and explore the literature is this topic here of a Laminar Crebosa. This is the area to where as the optic nerve begins to form by it exiting the posterior orbit, it has to go through a mesh-like structure back here. So let's just spend just a little bit of time here on the Laminar Crebosa, and as we progress in this talk, you'll understand why it was important that we mentioned it just a little bit early. And so really what that Laminar Crebosa is it's nerve fibers forming the optic nerve exit the eye posterior through a hole in the sclera that is occupied by a mesh-like structure called the Laminar Crebosa. Let's take kind of a closer look at that with a different picture. And here you can see as these nerves are forming and coming back to coalesce into the optic nerve, they pass through this Laminar Crebosa here. But if we looked at a different image here to where we cut it straight on, this is what it looks like right here. You would see that the optic nerve sheath here is composed of all these individual axons, and all of these individual axons here have to go through that mesh-like structure. And why is that important for us to know? That's important for us to know because in our topic here that we're discussing of increased intracranial pressure is that if you had pressure gradients down here where you had increased ICP, that would translate into higher pressures to where it could possibly push out some of these nerve fibers here, and that might stretch the Laminar Crebosa. So why do I mention that here at this particular juncture? Well, as we look at measurements of the optic nerve, you're going to see that it kind of looks like a shadow, and you're measuring a black tubule. And there has been some topic and some discussion that perhaps maybe you're not measuring the optic nerve itself. Perhaps maybe you might be measuring that Laminar Crebosa shadowing that comes down. And here I just wanted to introduce early in this particular talk that maybe that's a moot point, because in instances of increased intracranial pressure, you're going to have dilation of that optic nerve sheath and or stretching of that Laminar Crebosa, and so you're going to have a widening no matter what of that shadow. So it almost does seem like a possible moot point as long as you're doing your measurements consistently. So keep that in mind as we begin to progress. So let's jump straight now into how to do this particular exam. And so the first thing that we want to do here is that we want to do this exam with a closed orbit. Now, often we're doing these particular exams on individuals that are intubated, sedated, otherwise comatose, low GCS scores, but we do just want to make sure that their eyelid is closed. After their eyelid is closed, we want to make sure that during the course of the exam that their eye would not open. And so what we do is we can put a tegaderm over their eye, and that covers the eye. The next thing that we want to do is we want to be sensitive to transmitting pressure on the orbit. We don't want to transmit pressure, but we do need to have the sound waves go back into the orbit. And so what you can do there is you can add a copious amount of gel on top of the tegaderm, and then you really don't need to put really hardly any pressure at all then on the gel, and nothing really will be transmitted for the most part to the orbit, and you'll be able to have your sound waves come through. So to make sure that you don't put pressure, it would be a good technique here for you to concentrate putting the palm of your hand really on either the cheekbone here or perhaps the forehead, depending on how you had your orientation of your hand. So this way, this acts as a stabilization device here to where you then don't transmit the pressure to the orbit. You're really transmitting any pressure at all to either the forehead here or to the cheek. So that would really be a much better form to use there. Next, what we want to do here is we want to take our measurements at a 3 millimeter depth. And we're going to painstakingly review some of the research in reference to that 3 millimeters depth and why we take it there as, say, a comparison to 5 millimeters or deeper or so. We want to also take the measurement in more than one plane. Here I list transverse and sagittal, and we'll review some of the literature in reference to why we want to take this particular exam in more than one plane. And lastly, the eye should be roughly symmetric. Now, there could be some minor asymmetry, but we shouldn't really expect to see any major differences between the eyes. So what I wanted to show here next was just really a quick video, and what you're going to see here is that we're just placing our probe on the eye. And as we place the probe on the eye, we're beginning to rock the probe back and forth, and eventually you get this shadowing that comes in right here. So it's really a very easy exam. You can see, put your probe on, you rock, and you're trying to bring this particular structure out, right back here. So let's now jump into some of the literature behind this examination. So this first paper here is Bedside Optic Nerve Ultrasonography for Diagnosing Increased Intracranial Pressure. And this is a meta-analysis here. And here we looked at 71 studies involving 4,500 patients. And what they found here was that the pooled sensitivity, specificity, positive likelihood ratio, and negative likelihood ratio of optic nerve sheath ultrasonography in patients with traumatic brain injury were 97%, 86%, 6.93%, 6.93, and 0.04 for the metrics that I listed above. And when these same metrics were looked at in non-traumatic brain injury patients, they were very similar. And so here it's important to note that they found an optimal cutoff for optic nerve sheath diameter of 5 millimeters, which is commonly what we use these days. That being said, as we progress in this talk, I will present one particular paper that used a lower cutoff, and we'll talk about that lower cutoff and when we might consider that. But a point to raise here in this particular paper here is notice that this particular paper here, as well as many of the other papers, were done in patients that had some type of brain injury. And what that translates into is that the pretest probability was high. Think about it. You're doing this particular examination on a patient that might have a closed head injury from a car accident, who's presenting to you with a GCS of 3, who's intubated. They have a very high pretest probability of having increased intracranial pressure. And so if you do your exam and you have a measurement that is 5 millimeters or greater, that is going to translate directly into the likelihood that you have an accurate exam. This would, of course, be something much different, whereas if you have someone that just comes into the outpatient clinic setting and they are completely in good health, and you did an optic nerve sheath examination and you had a measurement of, say, 67 millimeters or something like this, 6.7 millimeters, something that was, very high or so, you would really kind of question the accuracy of that. So pretest probability is what I really want to drive home here. So coming back to some of our papers here, the next one I want to talk about here is the reproducibility and accuracy of optic nerve sheath diameter assessment using ultrasound compared to magnetic resonance imaging. And so here they looked at 15 healthy volunteers, and again, they did their exam with optic nerve sheath examination and with a 3 Tesla MRI magnet. And what they found was that comparing ultrasound and MRI derived optic nerve sheath diameter values, they found an acceptable agreement between both measures for measurement at a depth of 3 millimeters. However, they also looked at 5 millimeters and the accuracy wasn't as high. So that's why we take our measurements at the 3 millimeter depth mark. It comes from this particular paper here. So let's continue to move on here, and let's take a look at this paper. And this is the correlation of optic nerve sheath diameter with direct measurement of intracranial pressure. So here the goals of this study were to evaluate the association between optic nerve sheath diameter and ICP, and to validate the commonly used threshold that we use of the 5 millimeters, as compared to really what would be the gold standard, which is a ventriculostomy in which we have direct pressure monitoring. And so here they looked at 38 ocular ultrasound exams that were performed on 15 patients, and they used the Spearman rank correlation coefficient for the optic nerve sheath diameter and ICP, which was 0.59, which is demonstrating a significant positive correlation. An ROC curve was created to assess the ability of optic nerve sheath to distinguish an abnormal ICP greater than 20. And what they found was that a value of 5 millimeters performed very well. So here, another validation of the 5 millimeter cutoff. So let's continue to look at some studies here. And this particular study here is going to give us slightly different results. And this one here again is optic nerve ultrasound for the detection of raised intracranial pressure. And they looked at patients in the ICU with either external ventricular drains or intraparenchymal monitors and at risk for intracranial hypertension. And again, they looked at an ROC curve was constructed to determine the optimal optic nerve sheath diameter for detection of ICP greater than 20. And what they found in this rather diverse patient population, 65 patients with varying injuries such as subarachnoid hemorrhage, traumatic brain injury, intracerebral hemorrhage, ischemic stroke, and brain tumor was that the cutoff here that they found had a higher sensitivity was 0.48. And so what I want to particularly emphasize here is that I don't really find a big difference here, not necessarily between 0.48 and 5. What I wanted to come back to, and why we spent time on introducing the concept of pretest probability, is that these measurements need to be taken into context. So again, if we revisit our patient, say with traumatic brain injury and a Glasgow Coma score 3, and they have a measurement of 0.49, your pretest probability is very high for elevated ICP. So I would take that very seriously and perhaps say that that is positive and initiate treatment accordingly or further workup. Compare that again to your outpatient clinic patient who's completely normal, who might have a reading of 0.49. You might want to look into other etiologies, etc. So really put that pretest probability into context. So lastly here, let's take a look at this particular paper. And this was interesting here. And again, it gives us some different information and some stuff that we could learn from it. And so this was a comparison of 3 point of care ultrasound views. So they looked at the optic nerve sheath in the inferior, sagittal, and transverse planes. And they compared that to MRI. However, this is a different study. Here, instead of using patients that had known ICP with a gold standard ventriculostomy and with some type of brain trauma, here these were healthy patients. And in this particular patient population, they found that the correlation analysis showed a wide variability in the correlation between different ultrasound views with magnitude range of 0.1 to 0.8 and directions being both positive and negative. And there was a difference in image quality scores between the ultrasound views. Here they found that the inferior and transverse orientations were superior to the sagittal orientation in achieving a high image quality. Comparison to MRI measurements did not demonstrate a significant correlation. And so how do I view this particular paper? Do I see a disparity? Well, again, this is in healthy individuals. The pretest probability might be lower, actually is lower in this patient population, but there is value in this paper in that this is where we get the thought that we should be taking our measurement in multiple different planes and views to get a more accurate global measurement and assessment of our patient. So, and this is really an example as such here. And so this is from a patient here where we took the measurement at the 3 millimeter mark down here, and they had a value here of 0.74. This is very high. However, I want to note that this was actually done in the outpatient clinic setting in an individual that happened to have inflammation of their optic nerve. And so it's really kind of important to put really the global picture together when you take these particular measurements. It's not just taking the measurement and then taking that as such. You need to put the whole picture into clinical play here. So lastly here, I just want to talk about this is the diagnosis of elevated intracranial pressure in critical ill adults. This was a systemic review and meta-analysis here. And here what they wanted to do was compare different ways of assessing ICP. Here using physical examination, CT scan, the optic nerve sheath diameter technique, and transcranial Doppler. And to really jump straight to it, they found that really the optic nerve sheath diameter performed the best. CT scan performed reasonably well. TCD actually did not perform so strongly. Physical examination had some wide variance. So this really strengthened the argument of using optic nerve sheath diameter in head-to-head comparisons with these different ways to assess ICP. So lastly, let's just take a look at maybe some shortcomings and some things that we want to do to troubleshoot to get the best exam. And so what we discussed here is false positives. And so in that one particular patient that we just talked about in the outpatient setting where they had inflammation of their optic nerve. That was an inflammatory infiltrate there, and or an optic neuritis, and you have to be cognizant of that. You have to put these particular measurements in context of the global picture here. Maybe you could have something similar with Graves' orbitopathy. You can have some individual pathology that can make determining sheath margins difficult. We did talk about the laminar crebosa here, and perhaps maybe that's not really so important. Perhaps maybe it's a moot point, considering that in ICP measurements you could have widening of the optic nerve and of that laminar crebosa. So even if you are measuring shadowing, it might not make a difference. The important thing is that you take your measurements the same way every time, especially serial measurements in the same patient. There are some disagreement between studies of the power correlation between views and correlation between MRI and ultrasound measurements, but again, that might not be as important as I highlighted in some of the studies. We looked at individuals that had brain trauma of some way, shape, or form, and individuals that were healthy. And so we need to put pretest probability into context here. But we did get the information that taking multiple views is helpful regardless. Here we can have some secondary artifact, and practitioners might not be measuring the true optic nerve sheath diameter, as we discussed when I talked about that laminar crebosa again, might not be something of concern to us as long as we're taking our measurements the same. And there could be some discrepancies in cutoff values for optic nerve sheath correlating to increased ICP, but again, coming back to that pretest probability, as long as you're putting these values into clinical context, this might not be so important. Lastly, I just wanted to take a quick look here at some troubleshooting. And so what you want to do here is you want to turn down your dynamic range. You want to take multiple views, as we've discussed multiple times. We want to measure the outer edges of the nerve sheath. We want to keep in mind that pretest probability. And here, to perform the exam safely, not only not putting pressure on the orbit, but you want to set your device, your ultrasound device here, to the lowest possible mechanical index and thermal index. So settings might not be customizable in all machines, and if it's not, you might want to include that in your informed consent for this particular procedure. For those of you that might be interested in some of the papers that we reviewed, here are direct links to those papers. Thanks for watching, and thanks for learning with us. Thank you so much for watching and learning with us today. If you're interested in taking this class for credit, or if you're interested in our other services, such as our direct clinical care services, please visit our website at www.med-specialist.net or click on the link in the description below. Also,